Okay, it's now recording. I think we'll be fine. I'll send the recording to the YouTube channel so that you can get it there. And you can always watch it at ×2 if you want to hear me rapping. You can always ×2. The scope for today is very easy. Reproductive system, urinary system, digestive system, easy stuff. We have covered the scope. We have already covered the other topics. We have already covered pharyngeal apparatus. That one we did. We also covered the development of the face. We also covered the development of the tongue, the development of the heart, the development of the lower respiratory tree. We also covered the development of the diaphragm and also describe the development of the limbs. We have already done that. What is not yet done for the systemic embryology are the 3 parts. And I will cover that. We start with reproductive, then urinary, and then digestive. If you give me, say, 2 to 2.5 hours, I'll be done, and you'll be ready for your exams. Okay. Oh, you also covered the breast. Yeah. Now, let's start with the development of the reproductive system. And when it comes to the development of the reproductive system, I need you to understand that there is a time during development where you cannot tell the sex of the fetus, a stage known as the indifferent stage. So the indifferent stage is the bipotential phase where the genitalia has full potential to either become male or female. That is known as the bipotential phase. And in the bipotential phase or the indifferent stage, you have an indifferent gonad, an indifferent internal genitalia, and an indifferent external genitalia. So remember, these are the 3 components of the reproductive system. A gonad, in males is the testis, in females is the ovary. The internal genitalia, in males, you have the epididymis, the ductus deferens, the seminovesicles, the ejaculatory ducts. Yeah. And then in females, the internal genitalia refers to the fallopian tubes, the uterus, the cervix, and the part of the vagina. That is the internal genitalia. Now, external genitalia is now what you see on the outside. In males, penis and scrotum. In females, the vaginal vestibule, okay? Or the components of the vestibule. Now, I can see you have already, you guys are already asking questions. What is happening? Yes, the lecture has been recorded, and yes, the lecture has been recorded. That's it. Okay, so so you need to understand what are the components. How do these structures? What are the components of the indifferent gonad? What are the components of the indifferent internal genitalia? And what are the components of the indifferent external genitalia? Now, for the indifferent gonad, it arises from the gonadal ridge. Now, the gonadal ridge is a ridge located in the intermediate mesoderm, just medial. It's found medial to the urinary ridge. Okay, the ridge which gives rise to the urinary system, the gonadal ridge is just found medial to it. Okay, then within that gonadal ridge, we have 2 parts, a cortex and a medulla. Okay, so you have a cortex and a medulla, and then the gonadal ridge is invaded by the pluripotent germ cells. You remember these pluripotent germ cells, which originate from the yolk sac and allantois, and then they migrate via the dorsal mesentery to find their way to the indifferent gonad. Okay, now the pluripotent germ cells are the ones which give rise to spermatogonia in the testis or oogonia in the ovary. Okay, now we have the indifferent internal genitalia. Now the precursor. So the reason I'm trying to emphasize this is because they can give you an exam and then they point, say, to the epididymis, and then they ask you, these structures are derivative of what? So you need to understand that, first of all, epididymis is in the male, and then it is part of internal genitalia. So anything from the internal genitalia in males came from the Wolffian duct. Okay, Wolffian duct, which is also known as the mesonephric duct. mesonephric duct. Anything internal genitalia in females came from the Mullerian duct, which is also known as the paramesonephric duct. Paramesonephric duct. Okay. Now, the indifferent external genitalia, you have three very important components. We have a genital tubercle, we have a urethral fold, and a labioscrotal swelling, or the genital swelling. Okay, the labioscrotal swelling or the genital swelling. Now, let's see how now these things come to be. Okay, so the gonads, the indifferent gonad lies medial to the mesonephric ridge. This mesonephric ridge is the one which gives rise to the mesonephrons are within the mesonephric ridge. Okay, so what is the site of development of the gonads? They arise from the gonadal ridge. What is the source of mesenchyme? The intermediate mesoderm. Okay, the intermediate mesoderm will give rise to those cords, the medullary cords and the cortical cords, and then the pluripotent germ cells. Now, the pluripotent germ cells give rise to the gametes. Okay, the gametes. What is the sequence here? I'll keep it easy. The medullary cords will develop in male, where the cortical cords will develop in females. So if this is the gonadal ridge, so you'll have a cortex on the outer part. So that's the cortex, and a medulla on the inner part. Okay, so what happens is that pluripotent germ cells will invade this gonadal ridge. Okay, and if this gonad is in an individual who has the genetic sex of XY, the medullary cords, the cells within the medulla, the reason I'm naming it as medullary cords is because the cells within the medulla are arranged in cords. The cells are arranged in cords. The medullary cords will be retained, but the cortical cords will degenerate. That is in a person whose genetic sex is XY. What about if the genetic sex is XX? Now, in a person whose genetic sex is XX, the cortical cords will be retained, whereas the medullary cords will undergo involution. Okay, so you need to understand that one key difference in the development of the gonads in males versus in females. Now, for this to happen, why is it that this is happening? It is because of the presence of what is known as the SRY gene, the sex-determining region gene found on the Y chromosome, which encodes for a protein or a factor known as the testicular determining factor, which this testicular determining factor is what now directs the indifferent gonad to be a testis. So if the SRY gene is not there, and when is the SRY gene not there? When the genetic sex is XX. If the genetic sex is XX, there is no SRY, so there is no TDF, and therefore the indifferent gonad takes a default pathway and becomes an ovary. So for you to develop an ovary, you do not require anything. It is simply a default pathway. But for one to develop a testis, you require an SRY gene, an intact SRY gene on the Y chromosome, which will encode for TDF, the testicular determining factor, which will now direct this gonad, the indifferent gonad, to become a testis. What about internal genitalia? Now, you have the Wolffian duct and the mesonephric duct. Now, these two, sorry, it's the same thing. Okay, it's like calling me Wallace and another one Shege. It's the same guy. So Wolffian or mesonephric duct in males. So under the influence of the testis, it is the testis which now dictates the development of the internal genitalia. Okay, so the gonads have to develop first, and then they direct the development of the internal and also external genitalia. Okay, so if one has now a testis, the Wolffian duct or the mesonephric duct will be retained, and it will undergo development to give rise to the male internal genitalia, and this includes the efferent ductus of the epididymis itself, the vas deferens, the ejaculatory duct, and the seminal vesicles. Please note that prostate, despite being a part of the male internal genitalia, does not arise from the Wolffian duct. What about the Mullerian or the paramesonephric duct in females? Now, here, estrogen, maternal estrogen, okay? It is the maternal estrogen which will now control the development of the Mullerian duct to form now the female internal genitalia. That is the oviduct or the fallopian tubes, the uterus, the cervix, and the upper 1/3 of the vagina. Please note that the vagina has a dual origin, and I'm sure you've seen this even in the blood supply of the vagina. You must have seen a vaginal artery coming from the internal iliac artery supplying the upper 1/3 of the vagina, and also another vaginal artery from the which artery is this? I keep on forgetting the name of that artery which supplies. It's a vaginal artery coming from the which pudendo, the internal pudendo artery, which supplies the lower part of the vagina. But all in all, vagina has dual blood supply because it also has a dual origin, okay? So the upper third is the one which comes from the Mullerian duct. Now, external genitalia, okay? We will see this, okay? Not necessarily in the next slide, but I'll show you this. But please note that the lower 2/3 of the vagina comes from the urogenital sinus. So the vagina has dual origin. Upper third and lower third, lower 2/3 have different origins, okay? So, yeah, I think I'll build more on this. If you have not gotten the concept by now, worry not. I'll keep on. You'll see me repeating some things, some themes, which I feel are very important for you to understand. So we have 3 types of sex, and I'm talking about sex, not gender. So please don't get me wrong. I said sex. So when it comes to matter sex, you are either male or female. But when it comes to matters gender, you are male or female, and there are 1,000 in between there, which I really don't care. So the genotypic sex, the gonadosex, and the phenotypic sex, those are the 3 types of sex. The other name of genotypic sex is the chromosomal sex. The other name of phenotypic sex, this is the anatomical. Okay, so those are the 3 types of sex. So the genotypic sex is determined during fertilization, and you are either 46XX, so this is a genotypic female or a genotypic male, XY. Okay, and this is based on the type of sperm that fertilizes the oocyte during fertilization. Okay, so when your dad and mom met, your dad produced either an X chromosome or a Y chromosome. So depending on which sperm shook hands with the ovum, if it was an XX, ideally, it should be a female. If it's an XY, ideally, you should be a male. Or rather, that is the normal, okay? But you'll see that in some cases, this is not the case. Then we have the indifferent gonad, what is known as the gonadosex, okay? So the indifferent gonad can either develop to an ovary or a testis. And this is, okay, I'm recording the meeting. I'm recording. What do you know? You'll get the recording. You'll get the recording. So I'm talking about the gonadosex, where you have an indifferent gonad. This indifferent gonad can either develop to an ovary or a testis. But now, what determines this? This is based on the presence of the SRY gene, which encodes for the testicular determining factor. Okay, the testicular determining factor. So it's the SRY gene on the Y chromosome, okay, which determines if the indifferent gonad will become a testis or an ovary. So for it to become a testis, you require an SRY gene, and this SRY gene is the sex determining region Y on the Y chromosome gene, which now encodes for TDF, testicular determining factor, which will now program this indifferent gonad to become a testis. So for the testis to develop, you require SRY and TDF. If these two are not present, the indifferent gonad by default becomes an ovary. Okay? So by default, you do not require any special thing for an ovary to develop. Okay? Now, the phenotypic sex is now the anatomical sex. Okay? It's what ideally you and I use to tell the sex of a person. Okay? So it is it's the internal and external genitalia. But in most cases, you use the external genitalia because that is what you can see. Okay? So remember, we have the indifferent internal and external genitalia. Now, this differentiation of these indifferent internal or external genitalia to now form the various components of the internal and external genitalia. For this differentiation to occur, you require androgen hormone activity. Okay, so androgenic hormones are required for the indifferent external and internal genitalia to undergo what is known as virilization. Okay, male patterning. So for this genitalia, the indifferent genitalia, I don't know why I'm getting very many people requesting to record. Guys, I'll send the recording. I'll send the recording by, trust me, by tomorrow morning, you have this recording up and running. Okay. Now, I was talking about the indifferent gonad. So this indifferent gonad, indifferent genitalia, external and internal genitalia. For this indifferent genitalia, for it to now become the differentiated genitalia, you require androgen hormone activity. This occurs in males, okay? The male patterning. So for the male patterning to occur, for this now indifferent internal and external genitalia, for them to now acquire the male pattern, you require androgens. And where do these androgens come from? Two sources, the fetal adrenal cortex, and the most important is the fetal testis. So if the fetus has a testis, these testis will produce androgens. Examples of androgens include testosterone. Testosterone is the one which now directs the internal genitalia to acquire a male pattern. And then a derivative of testosterone, known as dihydrotestosterone, is the one which now it now tells the indifferent external genitalia to acquire the male pattern also, okay? So what am I saying? Androgens are required for male patterning to occur. If androgens are not there, then the indifferent external and internal genitalia by default acquires the female phenotype. Okay, so you need to understand that for the male gonad, for the male sex organs to be formed, you require a Y chromosome, an intact Y chromosome. That Y chromosome is the one which will encode for the testis. And after the testis has been formed, this testis has to be functional for it to now further direct the indifferent external and internal genitalia to now give rise to the male internal and external parts, genitalia, that is, okay? So those are the three types of sex, and you need to understand them, okay? Now, what are the sources of fetal hormones? Fetal hormones come from either the placenta. Placenta produces estrogen. Same to the maternal ovary. The fetal adrenal cortex, irregardless of the gender, irregardless of the sex, let me use sex, not gender. Regardless of the sex, whether male or female, the adrenal cortex will always produce androgens. Irregardless, whether you are either female or a male, it will produce androgens. But the fetal gonad here, especially the testis, is responsible for virilization. That male patterning is what I'm referring to as virilization, okay? That is done by the testis, okay? So I want you to think of a scenario where you have what is known as congenital adrenal hyperplasia. Congenital adrenal hyperplasia, as the name suggests, the adrenal gland is overstimulated, or it is producing a lot of androgens. So if the adrenal cortex is producing a lot of androgens, and you are, say, a genotypic female, so you are a genotypic female, you are XX, but if you are XX, you'll have an ovary. By default, you'll have an ovary. But if you have a congenital adrenal hyperplasia, because there'll be a lot of androgens within circulation, you will now have male internal and external genitalia. That can happen. So you have an ovary, but the external and internal genitalia are those of a male. So these people, they will be brought up as boys, because okay, at birth you simply look at what is this fetus possessing. Is it a penis or is it a vulva? And you assign them the sex based on that. So because they'll have male external genitalia, they'll be brought up as boys. But it will reach a time where now the ovaries will become stimulated and they start producing estrogen instead of testosterone. And now you can imagine what will happen. These so-called boys will now start growing breast. And now you can be able to now connect some dots. If you visit the Philippines, you will be amazed by the number of lady boys who are there. You can now explain the anatomical basis of these lady boys. Okay. You've not visited Philippines. Tafuteni pesa. I'm joking. Now, the ovarian development. Now, remember what he said in the ovary? It is the cortical sex cords which proliferate, whereas the medullary sex cords degenerate. The pluripotent germ cells gives rise to the oogonia, whereas the follicular cells, these follicular cells usually arise from these cortical cord cells. Those cells which comprise the cortical cords are the ones which give rise to the follicular cells. Remember, the follicular cells are the supporting cells for the ova, okay? Those come from, in fact, the surface epithelial cells, what is known as the coelomic epithelium. Coelomic epithelium. So if they give you that in your exam, they point to the follicular cells and ask you what is the derivative, or where this is the derivative of what? It came from the coelomic epithelium, or simply the surface epithelium of the gonad. Remember, in the testes, on the other hand, it's the medullary cords which differentiate, whereas the cortical cords degenerate. Spermatogonia come from the pluripotent germ cells. The Sertoli cells come from the surface epithelium. Remember, the Sertoli cells are the supporting cells from the spermatogonia. So like Sertoli cells is an equivalent of follicular cells in male. Follicular cells are the supporting cells of the oogonia in females. Sertoli cells are the supporting cells of spermatogonia in males. So they have the same origin, which is the surface epithelium or the coelomic epithelium. But now, the interstitial cells of Leydig, these ones come from the intermediate mesoderm, the mesenchymal cells. Those the intermediate mesoderm is the one which gives rise to the Leydig cells. Let me finish this discussion there of the gonads. More will be said when you come to that year pathology, where now they will teach you about tumors of these gonads, and you'll see very interesting tumors. Okay, very huge number of tumors which can arise from this simple anatomy, which I'm trying to describe here. Okay, let us see what we have. Oh, this is a blank slide. Okay, now this is the slide which now describes the development of the external genitalia. Okay, the external genitalia. Remember, you have very important structures: a genital tubercle, okay, the ureteral fold, okay, or genital fold, and the genital swelling, which is also known as the labioscrotal swelling, okay. And you can see it there. Those are the very important structures which you need to understand, which give rise to the external genitalia. Okay. Now, this is the stage. No, this is the indifferent stage. You can see it's the indifferent stage. Okay. At this point, you cannot tell is this a male or a female. Okay. Now, what happens is that the genital tubercle elongates slightly to form what is known as a phallus. Okay. So phallus and the genital tubercle, it's one and the same thing. Okay. But now in males, male patterning occurs, and this male patterning is by the help of androgens. It's androgens which direct this in males, especially dihydrotestosterone. Okay, dihydrotestosterone. Now, dihydrotestosterone comes from testosterone. Okay, testosterone has to be converted to dihydrotestosterone by an enzyme known as 5-alpha reductase. You'll be taught this in your, I believe, physiology second year, if you have not been taught. Now, 5-alpha reductase converts testosterone to dihydrotestosterone. Now, I want you to think about a situation where, and okay, let me emphasize this at this point. Testosterone is the one which encodes for the internal genitalia. So for the development of the internal genitalia, you require testosterone. But external, you require dihydrotestosterone. You need to understand that point. Now, I want you to think of a situation where you have a deficiency of this enzyme, 5-alpha reductase is deficient. In these individuals, they'll have the gonads will be testes, okay? The internal genitalia will be that of a male, but because they cannot form dihydrotestosterone, the external genitalia will be that of a female. So these individuals are the complete opposite of what we earlier described for the lady boys. Now these ones, the external genitalia will be of a female, but when puberty hits, my oh my, they start, their voice deepens, their shoulders broaden, they grow beard, and the parent wonders what is happening. Okay, so these individuals will be brought up as girls, but they will reach even the age of 14, 15, 16. They have not seen their menses, and that is now what we bring them to the hospital. Okay. Now, for males, this phallus will continue to elongate. The phallus will continue to elongate and give rise to the penis. The genital fold here will fuse. You can see the genital folds are fusing in males, and this urogenital sinus is incorporated within the penis to give rise to the penile urethra. So the urogenital sinus in males will give rise to the penile urethra. Okay, will be incorporated. So this urogenital sinus will be incorporated within the urethral fold to give rise to the penile urethra. The genital swelling or the labioscrotal swelling in males will become the scrotum, and everything is shown there, okay, in the late fetus. Now here you can tell that, okay, this keeps on popping. Let me hide this. Okay. Now from this one you can legit tell this is a male. Okay, it's no longer indifferent. Okay. Now in females, remember, in females, it's a default pathway. You do not, if androgens are not there, the phallus will not elongate further and will give rise to the clitoris. The urethral folds will not fuse. Okay, they will not fuse, and they form the labia minora. Okay, the urogenital sinus therefore won't be obliterated, and therefore in females it gives rise to the vagina, the vestibule. Okay, the vestibule in females, the vestibule. From now, which you will see the openings of the vagina and urethra. The genital swelling or the labioscrotal swelling will simply elongate craniocaudally. Okay, they elongate craniocaudally. They do not fuse. Remember, in males they fused to give rise to the scrotum. In females they do not, and they give rise to the labia majora. Okay, even when I'm sure you've seen this, even when describing the sensory, the blood supply of the scrotum and the labia, you must have said anterior 2/3, posterior 1/3. even the nerve supply, you'll see the nerves are the same, only that for females, they'll be known as labial branches, for males, scrotal branches. But the source of these branches, whether nerve or blood vessels, the same thing, the same, they come from the same structures, the same vessels or nerves. Okay, I'm sure you saw that. If not, please go and revisit your anatomy, your gross anatomy. Okay, so in simple words, in males, the active sex hormones, androgens, especially dihydrotestosterone, DHT, which causes virilization, male patterning. The genital tubercle will elongate, form a penis. Urethral fold will be pulled, fuse, and become incorporated in the penis as the penile urethra. The genital swellings will also grow medially and fuse and become the scrotum. And now this will house the descendant testes. And by the way, everything which we said about the testes, when you are developing the testes, the indifferent gonad, that stage occurs in the abdomen. That stage occurs in the abdomen, okay? In the abdomen, where the future kidneys actually should be, where your kidneys, where you and I have our kidneys, that is where the gonads were initially, even for females. That is where the gonads were initially, where the kidneys are at right now. Okay, so in the lumbar region. But in males, they descend and they come out of the abdomen. In females, the gonad simply descends, but it just goes to the pelvic cavity. Okay. Now, in females, estrogen is the main hormone. This estrogen does not come from the fetus, it comes from the mother. So the fetal ovary is hormonally silent. Get that point. The fetal ovary is hormonally silent, but the fetal testis is hormonally active. Okay, so because of the presence of maternal estrogen, there is no fertilization. So default pathway, genital tubercle will slightly elongate to form a clitoris. The urethral fold will not fuse and become labia minora. The urogenital groove, that groove will become the vestibule. The genital swellings would fuse, but will expand longitudinally to form the labia majora. Great, and you are done. You are done with the development of the male and female genitalia. You are done. You are done. That's it. So here is to just show you the mesonephric duct. So remember we shall discuss this, but let me say this in passing. During the development of the what is it called? The urinary system, you have 3 sets of kidneys or 3 sets of urinary systems usually develop. What are known as pronephrons, mesonephrons, and metanephrons. The pronephrons are about 7 in number, and they are found in the cervical region. Okay, they develop around week 4. However, pronephrons do not have a functional renal corpuscle. So they do not have a renal corpuscle, and for that reason, they cannot form urine. So they simply degenerate. They undergo involution after 1 week. Okay, so they are in the cervical region, no renal corpuscle, involute at the start of the 5th week. Okay, so they are just around for 1 week. They do not stay for long. They just involute after 1 week. Then in the thoracolumbar region, 40 mesonephrons develop, and they form the mesonephric ridge, which is just lateral to the genital ridge in the intermediate mesoderm. Now, these ones have a functional renal corpuscle, so they can form urine, and that urine is drained by the mesonephric duct. And you can see this is the mesonephric duct, which drains into the cloaca. And see, the mesonephric duct will collect urine from the mesonephrons and drain it into the cloaca. Now, the cloaca is simply the common channel between the allantois and the hindgut. Okay, the allantois and the hindgut. That common communication is the cloaca. Okay, and the cloaca is ideally undergoes septation in mammals. Okay, and you and I are mammals. It undergoes septation anteriorly to form the urogenital sinus, which will give rise to the bladder and the urethra and part of the genitalia, and then posteriorly it will form the anorectal canal, which will give rise to the anus and the rectum. Okay, I've said that occurs for mammals. That is why your urinary stream and your fecal stream are two different pathways. But if you go to birds or reptiles, I'm sure if you have chicken at home, have you ever seen chicken urinating? If you see a chicken urinating, then that would be a very weird occasion. I've never seen chicken urinating because they have a cloaca. And the cloaca in chicken is maintained, or in other birds, maintained. You won't see a bird going for a short cut because they have a cloaca. And for that reason, whatever ideally should come out as urine mixes with the fecal material, and that comes out as that material. Okay, I don't know how to call it. Fecal urine. I don't know how to call it. Okay, so that is how mesonephrons develop. But mesonephrons also do not give rise to the definitive kidney you and I have. They involute, okay? But in males, some of the mesonephrons, these are the mesonephrons, some of them are retained. And actually, the mesonephrons are the ones which give rise to the efferent ductules of the epididymis. The mesonephric duct is also maintained in males to give rise to the male genitalia. But in females, everything here will involute. It will involute. And what you see are some remnant structures within those supporting ligaments of the uterus and the ovary. I'm sure you've seen of those epiphron, ophron, Gartner cyst, those minor structures within the broad ligament. Those are structures which are remnants of the mesonephric ducts. Okay, so you need not to remember them, by the way. Okay, you need not to go and cram those derivatives of the mesonephric duct in females. You need not to bother yourself with that. Just know in females it involutes. But now, the definitive kidney which you and I have come from the metanephros, which originates in the pelvic region. Okay, so in the pelvis, that is where initially your kidney was. Okay, so the metanephrons give rise to the secretory portion of the kidney. So the kidney, the urinary system, I usually take the urinary system has two parts: a secretory portion and a collecting portion. Okay, the secretory portion are the nephrons. So the nephrons, the 2 million nephrons you and I have, came from the metanephros. But the collecting system came from this diverticulum. You can see this diverticulum there, what is known as the metanephric diverticulum or the ureteric bud. That is that which gives rise to the collecting system. The collecting system refers to anything distal to the nephrons. So after the nephrons, the nephron usually ends at the distal convoluted tubule. That is where the nephron ends. After that, everything else came from the ureteric bud. So I'm talking about the collecting duct, okay, the collecting ducts, okay, the minor calyces, the major calyces, the renal pelvis, and the ureter. Those structures came from the ureteric bud. Please, they'll ask you this in your end of year. They will point to the renal pelvis and ask you the structure pointed is a derivative of what? Please remember, renal pelvis is part of the collecting system, so it came from my ureteric bud. Simple. And you get your 1 mark and you move on to second year, and we are happy. Okay, if they point to the nephron, then it's a secretory portion. So it came from the metanephrons. Easy. Okay, so you just need to understand, where does the nephron end? After the nephron has ended, everything else after it came from the ureteric bud. Okay, up to the level of ureter. Bladder does not come. The bladder does not come from the ureteric bud. I'll tell you where the bladder comes from. Okay, so these are the mesonephrons, which now give rise to in males, the male internal genitalia. Now, lateral to them in females, you'll see that lateral to them, that is where the Muravian duct or the paramesonephric duct. The paramesonephric duct usually develop lateral to the mesonephric duct, okay? And these are the ones which now give rise to the female internal genitalia. Okay, and yeah, I think this is a very good illustration of the same. You can see this is the Wolffian duct. So this will give rise to the male internal genitalia. Lateral to it is the Muradian duct or the paramesonephric duct, and this is the one which gives rise to the female internal genitalia. Please note this, very important. You can see that the cranial part of the Muradian duct, you can see it is funnel shaped. And you see that it's funnel shaped. And maybe you can start to think, why is it that the oviduct has an infundibulum? Why does it have that funnel shaped part? Could it mean that that was the part of the Muradian duct? And if that was your line of thought, then you are correct, okay? And then you can see that this paramesonephric duct, the Muradian ducts, please note that the caudal portion, you can see that the caudal portions fuse. The caudal portions fuse. But for the case of the Wolffian ducts, you can see that they remain as two separate structures, okay? So that is another key difference, because this will be very important when we discuss in depth the development of the female internal genitalia. Female internal genitalia. Okay, so I think this is what I have been trying to say. If this is the chromosomal sex, the genotypic sex is 46XY, then because of the Y chromosome, it has the SRY gene. SRY gene we code for TDF. TDF will make the indifferent gonad become testes, and then your testes will produce androgens. And then the androgens, together with the Sertoli cells produce a substance known as MIH. I'm sure you've heard of MIH, Muradian inhibiting hormone. Other texts will tell you MIF, Muradian inhibiting factors. Others will name it as anti-Muradian hormone. Same thing, eh? So this Sertoli says this factor, the Muradian inhibiting factor or hormone, causes regression of the Muradian duct. The androgens sustain the development of the Wolffian duct, which now gives rise to the male internal genitalia, all the way from the efferent ductus of the epididymis until the seminal vesicles, okay? The seminal vesicles. So if they give you that spot, you know, they point to the ejaculatory duct, and then they ask you, this structure pointed here is a derivative of what? Please just remember it is part of male internal genitalia, and that must have come from the Wolffian duct or the mesonephric duct. And you get your 1 mark and you move to the next question. What about if you are 46XX? So this means no SRY gene, no TDF. Estrogen will be the prevalent hormone, so no androgens. Estrogen levels high. Wolffian duct will regress, Muradian duct will develop, and now it will form the fallopian tube, the uterus, the cervix, upper 1/3 of the vagina. Now, this Muradian duct, the Muradian duct, this Muradian duct will attach to the upper part of the urogenital sinus to form what is known as the Muradian tubercle or the paramesonephric tubercle. So this is simply what I'm trying to say. So you have the two. So imagine these are the two Muradian ducts. They have already fused to the lower part. So this is the urogenital sinus. Okay. So the point at which they attach, you form a tubercle. This tubercle here is the one I'm naming as the Muradian tubercle. And the Muradian tubercle, it is from the Muradian tubercle that you now get the vagina. Okay. The vagina will develop from the Muradian tubercle. Okay. So this is what I'm trying to show you. You can see the two mesonephric duct join in. So this is the Muradian tubercle. And then you can see that the Muradian tubercle actually elongates in size. And then you can see that we have cavitation. Okay. The way the vagina is formed is that it is formed from the inside. Okay. So those cells which form this Muradian tubercle, once it has elongated, it now ceases to be named as Muradian tubercle. It now acquires the name vaginal plate. Okay, it's a cord. It's this solid. It's a solid structure. Okay, but you and I know that vagina is not a solid structure. It's a hollow structure. So you need that canalization has to occur. But how it occurs, it does not occur from the outside inwards as you'd expect. No, it is those cells on the inner part undergo apoptosis. They simply die off, and now they form cavity, which is the vagina. And you can see that the upper one that in red, that one came from the Mullerian ducts, and you can see that the lower one that actually comes from the urogenital sinus, the urogenital sinus. Now, please note that the vagina is not initially at birth, it does not connect to the external. You have a thin sheet of cells which separates the vagina from the external environment, known as the hymen. Okay. Now, the other thing which you need to understand is this. You can see you have two Mullerian ducts. You can see that they fuse, and then this septum between the two has to degenerate. Okay, so that uterine septum, initially, the uterus is septated, it's separated. You have two uterine cavities, but these two uterine cavities, that septum between the two has to involute, has to die off. I want you to think in the line of what if it does not involute. The other thing which could go wrong is what if one of the Mullerian ducts, simply involutes, one of the Mullerian duct does not develop, what will happen? Okay, I want you to think in those lines. Okay. Okay, you will see a very wide spectrum of anomalies from that. So I think I've described this. So this is simply a side view. You can see this is the uterine canal. You can see the point at which it joins to the urogenital sinus. You have that Mullerian tubercle, and then it elongates to form the vaginal plate, and then the cells of the vaginal plate undergo apoptosis to form the vagina, but it does not communicate with at birth, it does not communicate with the external. You have a separating structure known as the hymen. The hymen does not have to break during as one loses their virginity. No, the hymen in fact breaks even before the girl reaches puberty. Okay, it's a very delicate membrane. It just breaks off naturally. Okay, that is why they are able to even to see the first menses by the age of 12, 13. Okay, if the hymen did not break, that means blood would simply accumulate in the vagina and not come out. Okay, so the hymen has to break even for this menstrual blood to come out of the female reproductive tract. Okay, so don't be the kind of guy who beats women because you have not seen a hymen. Some traditionals. Okay, nonetheless, now we have gotten to the anomalies. Now look at this one. Can you tell me what is happening here? Can someone name these anomalies? Name these anomalies, guys, very fast so that we can finish. And we can finish within the stipulated time. Okay, I'll have to join with another device so that I can see your answers. Okay, let me try to join with my phone, but I don't know what will happen. No, it's not a must. I join with another device. And now the thing is, okay, let us see what you are saying in the chat box. 11 new messages. Oh my. 12. Oh my. What is happening? I can see. Very good, very good. Very good. Middle rectal. Yeah. Thank you for that. Yes, it's the middle rectal artery which gives rise to the lower part. I was there last weekend. Where? Then what bleeds? What bleeds? What is the context of this question? Ambiguous genitalia. Yes, all of you are correct. Atypical genitalia, intersex disorders. Very good. Yes, very good. Okay. Very good. So these are the intersex disorders. These are the intersex disorders. Okay, and those are the three causes of intersex disorders. Okay, it can be a structural or numerical abnormality of the sex chromosome, or you are XY, you have XY, but you have insufficient androgen. Okay, or you have XX, but you have excessive androgens. Okay, so you'll have these intersex disorders. So this one you cannot tell, is this a male or a female? You can't tell. Also, this one looks more of a female, but the labia majora look like they have some form of virilization. Okay, so it's difficult to tell. So they have ambiguous genitalia. So when do you suspect ambiguous genitalia? When they have atypical genitalia, or if the clitoris is too big, or if the penis is too small, or they have a penis but they have a very severe hypospadia, or they have a scrotum but testes are not palpable, or they have a gonad but it has both some portions are ovary, others are testes. So what is known as an ovotestis, or if they have gonadodysgenesis. Okay, what is this? I'm sure you've seen this. Sure you've seen this. Yes, very good, very good. Very good. Nice, nice. Cryptokidism, very good. So this put it unilateral cryptokidism, or right cryptokidism, because you can literally see the left testis is there. So it's a unilateral cryptokidism. There are very many theories of how testes descend. Unless you are planning to do BSc, I won't bother you with them. So that's cryptokidism. Okay, so here we have Muradian duct anomalies. So this is how a normal uterus should look like. But now look at this one. In this one, you can see that the two Muradian ducts did not fuse. So this person has two uterine horns. These are the conum, the two uterine horns, two uterine cavities, and two vaginas. I did not say two husbands. So that is known as the uterine didelphys. So in uterine didelphys, you have double. So this is the person who is blessed, because two vaginas, two uterine cavities, two uterine horns. Okay. So if you ask me if this can hold a fetus, no, it can't. Okay, it can't, because the fetus requires room for expansion, and these are tubular structures. They have the structures of the structure of the uterus here is somehow akin to that of the oviduct, and if a fetus is in there, it can rupture. Okay, so most of them are infertile. Then you have the arcuate uterus here. Now, what is happening here is that you can see that the fundus did not balloon outwards. So normally, the two Muradian ducts, after fusing, the upper part should balloon outwards or upwards. But in this case, that part where the two Muradian ducts met, the cranial part, it did not balloon outwards. So that's known as an arcuate uterus. Then in this one, it's a uniconvate. You just have one horn. So what happens here is that one of the Muradian duct involutes. Okay, it involutes. In this one, it's a biconvate. You can see that what happens here is that the two Muradian ducts fuse, but incomplete. There is incomplete fusion of the lower part of the Muradian ducts. So as shown here, and biconvate uterus can be of two types. So it can be, you have two uterine cavities and the cervix is in two. You have a pair of cervix. So this is known as biconvate bicollis. Or as shown in this one, where you have two uterine bodies but one cervix, that's biconvate unicollis, okay? Or the double uterus. Then this one, remember what we said? That uterine septum has to degrade, okay, has to involute. So if it does not, you have the septate uterus. Okay. Now look at this one. It's a micropenis. Now look at this one. This guy is blessed. He has two. So that's a bifid penis. So the micropenis, you might want to do further investigation to find out, is this an intersex disorder? Okay. Now look at this one. This one, this is the, okay, that's the rectum there. The part of the vagina is there, but we can't see the uterus here. Okay, so that's uterine agenesis. Okay, that's uterine agenesis. So these people are infertile by default because the uterus is not there. Now in this one, you can see that the urethral opening is on the ventral. It's on the ventral part of the penis. It's on the ventral part of the penis. So that is what is known as hypospadia. And such as this one, this is a very severe hypospadia. So this is also another criteria for intersex disorder. Now, if the urethra opens on the dorsal part of the penis, that is an epispadia. And epispadias are mainly found in the bladder extrophy. Okay, bladder extrophy. That is where you find epispadias. Yeah, and I am done with the development of the reproductive system. I am done and dusted. Next, allow me to go to the, we have just taken almost an hour for that. Allow me to just take 10 to 15 minutes and I'll be done with the development of the urinary system and then give you a break of 10 minutes. And then we come back and do digestive system very fast. Now, development of urinary system. What is the site? I'm sure you know this, intermediate mesoderm. Same case for the genital system. So from the urinary ridge, which is just lateral to the genital ridge, what is the source of mesenchyme? The mesoderm itself. Okay, so the site is the urinary ridge on the intermediate mesoderm. The source of mesenchyme is the mesoderm. And in this case, I'm talking about the kidney, which you and I have, the definitive kidney, which comes from the metanephric blastema, which gives rise to the nephrons, I have said, ureteric bud, which gives rise to the collecting portion. So anything distal to the nephron, but proximal to the bladder. So ureter, renal pelvis, major calyces, minor calyces, and the collecting duct. Okay? Those are the derivatives of the ureteric bud. What is the sequence? Now, the most important sequence here is kidney ascent. So the metanephric blastema is initially in the pelvis, okay? But that kidney has to ascend, okay, for it to be located in the lumbar region, which is the definitive position. But remember what I said, you have 3 kidney system, nephrons, 7 in number, do not have a renal corpuscle, found in the cervical region, appear in the 4th week of development, regress by the 5th week. They just stay 1 week. After that, they vacate. Mesonephrons, 40 in number, thoracolumbar region, they are functional. So they have a renal corpuscle. So they form urine. That urine is drained by the mesonephric duct. Okay. And they are the main kidney system from week 5 to around week 8, the 2nd month. Okay. So they are the main kidney system from week 5 to week 8. They involute completely in females. In females, they involute completely. Okay. In males, the mesonephric duct forms the male internal genitalia. The mesonephrons themselves form the efferent ductules. Okay, then the metanephrons are found in the pelvis, where they arise as a metanephric blastema. So you have some collection of metanephrons. They collect to form this bundle. It's like an aggregate of metanephrons known as the metanephric blastema, which now gives rise to the secretory portion of the kidney. Okay, the secretory portion, the nephrons. The nephrons. The ureteric bud, on the other hand, gives rise to the urine collecting portion. So anything from the collecting duct to the ureter. But now you'll ask me this question. The metanephric blastema and the ureteric bud are two different structures. So there is need for these two to communicate with each other. Otherwise, urine which would be formed in the nephrons would not find its way to the collecting ducts, to the ureter, and eventually to the bladder. So there is need for communication between the structures derived from the metanephric blastema and the ureteric bud. So I want you to ask yourself this question. What would happen if this communication between the ureteric bud and metanephric blastema was not established? I'll tell you, urine would accumulate in the nephrons. And if urine accumulates in the nephrons, those nephrons will simply dilate outwards. So you'll have that polycystic kidney, okay? A polycystic kidney, because urine is not being drained. The urogenital sinus gives rise to the urinary bladder and urethra. Okay, and remember urogenital sinus, allantois is part of it. So only the lower part of the allantois is incorporated into the urinary bladder. The cranial part becomes the urachus, which in adults is represented by the median umbilical ligament. Okay, the median umbilical ligament. Okay, so this is what I'm trying to say. You can see these are the mesonephric tubules. These mesonephric tubules are the ones which give rise to the efferent ductules of the epididymis. This is the mesonephric duct, which gives rise to the male internal genitalia there. And this partly explains why the urethra, why is it that the urethra in males has both reproductive and excretory function. You can get the idea from here, because you can see that the metanephric duct or the metanephric duct here, or the ureteric bud, you can see it is simply a derivative from the mesonephrons, and the mesonephrons give rise to the male internal genitalia. Okay, so this ureteric bud, you can see it communicates with the metanephric blastema. So the metanephric blastema is what will give rise to the kidney itself, okay, or the nephrons. Let me put it, the nephrons. The nephrons come from the metanephric blastema, but anything else will come from the ureteric bud. So the collecting duct, minor calyces, major calyces, pelvis, ureter, that will come from the ureteric bud. So there is need for these two structures to communicate, so that once urine is formed in the nephrons, it can find its way to the bladder. And you can see that this metanephric duct, you can see it is draining to the cloaca, but you know the cloaca will undergo partitioning, okay, by that urorectal septum to form anteriorly to form the urogenital sinus, and posteriorly the anorectal canal. So this mesonephric duct will open in the anterior part. It will open into the urogenital sinus, and part of the urogenital sinus forms the bladder, okay, the bladder. Okay, so you can see that initially the kidneys were in the pelvis, okay, in the pelvis, and I want you to see that within the pelvis, the renal arteries, when the kidneys were in the pelvis, came from the common iliac, Okay, so there was a time in your life when the renal arteries came from the common iliac, but you can see the kidneys have started to go up. They start to ascend, and as they ascend, you can see that the source of the renal artery changes. So initially it was in the common iliac arteries, and then it changes to go to the lower part of the abdominal aorta. So as they move upwards, their renal arteries also change. Okay, so that involutes, so that one will break down, another one will form. So break down, another one will form. Okay, so I want you to ask yourself, what could happen if these renal arteries, these former renal arteries, what could happen if the former renal arteries failed to involute? If they failed to involute, you would have an accessory renal artery. Accessory renal arteries are compatible with life. You can live even 100 years and you have an accessory renal artery. The only issue is you are not a good candidate for renal transplant. We your kidneys can't be used for transplantation because they have two sources of blood. Okay, and for that reason, some segments of the kidneys are supplied by a different, the accessory. Some segments of the kidneys are supplied by an accessory, whereas others are supplied by the main renal artery. So that is an issue. Okay, so but the quality of life is unaffected. Also note something also interesting here is that the gonads descend whereas the kidneys ascend. Gonads descend, kidneys ascend. Now these are the anomalies. So that kidney is fine, but what is happening here? Too small. So renal hypoplasia. So it might be that the metanephric blastema, the mesenchymal cells which form the metanephric blastema did not proliferate. So under proliferation of the metanephric blastema. So fetal ovulation, okay, this is normal. So the renal kidney, renal kidney, what am I saying? The fetal kidney usually has lobules, okay? That's normal. If you take the fetal kidney, it has lobules, but these lobules usually fuse to form that smooth kidney in an adult. Now, if you look at this one, you can see that the right kidney is there, but the left one nowhere to be seen. So that's renal agenesis, okay? Renal agenesis, unilateral renal agenesis. This is multicystic kidneys or polycystic kidneys. You can see cyst. This is failure. So this cyst contain urine, and it is failure of the metanephric blastema to form communication with the ureteric bud. So remember, ureteric bud, UB, ureteric bud gives rise to the collecting system, the collecting system. So it's the one which collects urine from the nephrons and delivers it to the bladder. So failure of that establishment of communication between the nephrons and the ureteric bud means that urine will accumulate within the nephrons and form cyst. Now this one, you can see that this is the lung, left lung, and you can see a kidney within it. So that's a thoracic kidney. So that kidney was over enthusiastic. It decided, let me ascend and ascend and ascend and until it went through the diaphragm and found itself in the thoracic cavity. Now, in this one, you can see that the kidney is here. It's in the pelvis. Okay, so here you have two anomalies. One, you have just a single kidney, so you have unilateral renal agenesis, and the kidney which is there is in the pelvis. So this one, you have both kidneys, that one and that one, but one of them has crossed to the other side. So you have what is known as crossed renal ectopia. And this one is a horseshoe kidney because the lower poles of these two kidneys decide to fuse. And most cases, horseshoe kidneys are found within the pelvis. They are found within the pelvis because they cannot ascend. The reason they cannot ascend to the definitive location is because of the inferior mesenteric artery. Remember, inferior mesenteric artery is a ventral branch. It's a ventral branch of the abdominal aorta. So if this horseshoe kidney tries to ascend, that inferior mesenteric artery will somehow hold it down. Okay, the inferior mesenteric artery will hold it down and it won't ascend. So horseshoe kidneys are mainly found within the pelvis. The pelvis. Okay, so more of this. Okay, here you can see. Here we are concentrating on the ureteric bud, the structures which came from the ureteric bud. Now note that in this one, on the left side, you can see that you have you can see you have two renal pelvis, two ureters. Same case here. This is the renal pelvis, another renal pelvis there, and two ureters. Okay. So that is known as the duplex collecting system. Okay, it is due to duplication of the ureteric bud. This one, on the other hand, is due to obstruction, what is known as ureteropelvic obstruction, and for that reason, you get accumulation of urine within the renal pelvis to form what is known as a hydronephron. Okay, a hydronephron. This one you can see that the ureter, first of all, okay, it is twisted, okay, it has that, it's like coiled, okay, spiral. and it is big. So that's a mega ureter. And most cases, a mega ureter is because there is an obstruction and urine accumulates within the ureter and becomes big in size. Now this one, you can see that this is the, yeah, you can see that's the aorta, and see that's celiac trunk, superior mesenteric artery. But now, inferior mesenteric artery is there. But now note this left kidney here. You can see you have a renal artery there, another one there, another one there. So those are the accessory renal arteries. Accessory renal arteries. They are compatible with the life, only that now you can't use this kidney for transplant. Okay, the other one is during the development of the inferior vena cava, which I won't bother you because the development of the inferior vena cava is one of those things which even myself, when I did an exam, we were tested that in BSc and I got nothing. Okay, development of the inferior vena cava is one of those topics which is just, I don't want to say complex, but it has a lot of details because the inferior vena cava comes from very many derivatives. But during the development of the inferior vena cava, if the inferior vena cava forms anterior to the ureter, if it forms anterior to the ureter, that ureter is compressed. Okay, so the ureter is compressed. So you, first of all, you have a mega ureter, but this mega ureter will be secondary to, will be due to the ureter being compressed by the inferior vena cava. So you can see that the ureter here is passing behind the inferior vena cava. So that's what is known as a retrocaval ureter. Okay, a retrocaval ureter. In most cases, it's the one on the right because, as you know, the inferior vena cava is to the right. Okay. Okay. So I think I'm done with, no, not yet. Okay, now bladder. Now in this one, this is what is known as bladder extrophy. What you are seeing here, whatever you are seeing here, this is the posterior wall of the bladder. In fact, this is the trigone. That's the trigone there. You can see the two openings of the ureter there. Okay, and the urethra really should start there. So what you are seeing is the posterior bladder wall. Okay, so this is a defect of the anterior abdominal wall. Okay, it's a defect of the anterior abdominal wall, and the bladder is exposed. So that's a bladder extrophy. Now here you have bladder diverticular. Okay, so maybe part of the bladder, part of the bladder wall is weak, and you get outpouchings. Okay, outpouchings of the bladder wall. Get those bladder diverticulum. I'm sure you remember this urethral development. I'm sure you remember urethral fistula, sinus, bladder diverticulum, and urethral cyst. That one we have described it. Then we have abnormalities of urethral development. So we have what is known as posterior urethral valves. So valves develop within the urethra, okay? The urethra, especially in males, where part of the urethra, a valve develops, and that valve cannot allow urine to pass through. So you get urine accumulating within the urethra. So what are those, and what are known as the posterior urethral valves? Then you have some fistula, as shown here, where the rectum might decide to communicate with the urethra. Okay, so you get what is known as urorectal fistula. Okay. Yes, that's it. I told you 10 minutes, 10, 15, and I think I have kept that. So I give you a break of 10 minutes, and then we come back. Please be back at 10:10. Please be back at 10:10 so that we start the development of the digestive system. This is the final part. After that, I will take questions, and then we finish the year. Okay.